Thank you. Thank you, sir. Okay. Thank you.
Okay, so I was saying thyroid hormones too are very powerful regulators of heart rates in that they cause upregulation of the beta-2 receptors. And if there's upregulation of the beta-2 receptors, it means that you have more catecholamines binding to beta-2 receptors, and then it will give you the same effect that I described earlier. And at the same time, they also increase the basal metabolic rates, which raises temperature. And we're going to see in the next slide that temperature also has an effect on heart rate, in that increase in temperature raises the membrane potential. And when it does that, there will be more firing or more depolarization of the cells, that's of the SA node, leading to an increase in heart rates. And if there's a reduction in temperature, it causes a reduction in the membrane potential, making the SA node or the pacemaker cell more difficult to depolarize. So increase in temperature causes an increase in heart rates, a decrease in temperature causes a decline in heart rates. And ions at the same time also affect the heart rates. Some ions will increase while some will decrease. Hypercalcemia, for example, or calcium, for example, affects heart rates. Hypercalcemia causes an increase in heart rates, while hypocalcemia causes a decrease in heart rates. If you have hypercalcemia, what happens is that you have more of the calcium rushing into the cell. I will know that calcium plays a major role in depolarizing cells, that's a SA node in this case. And the more the cell depolarizes, the more it's going to fire, and then the more the heart rates. Hypoxia too, in a way, affects heart rates, in that when there's hypoxia, it causes stimulation of the peripheral chemoreceptors that will activate the respiratory centers, or rather the respiratory center. And we know that the respiratory and the cardiac centers are in close proximity. So in a way, hypoxia also, activates the cardiac centers, leading to an increase in the heart rate, though this is a minimal effect or a minor effect compared to its effect on the lungs. Now, age also has a role to play in an individual's heart rate, in that we have a higher heart rate in infants. This is because they have a higher basal metabolic rates needed for growth. So I mentioned earlier that an increase in basal metabolic rate raises the body temperature, and that causes an increase in the membrane potential that will make the cells depolarize faster. Then females too have a higher heart rate when compared to males, said that females have a smaller heart. And so per stroke volume, the males will pump out more blood than the females. So the female's heart needs to beat faster in order to keep up with the cardiac output that is needed to meet the needs of the metabolizing tissues. So that's it for heart rates. The next thing is stroke volume. And stroke volume, is the volume of blood pumped from the left ventricle per beat. Now, we know that during the relaxation phase, that's diastole, the heart fills the blood. At the end of diastole, the blood that is in the heart is known as the end diastolic volume. Now, the heart begins to contract. When it does that, it ejects some of the blood that is in the ventricle at the end of diastole. And that blood that it pumps out is the stroke volume. That's the blood it pumps out per beat. Now, whatever is left in the ventricle is known as the end systolic volume. So to get the stroke volume, is simply you subtract the end systolic volume from the end diastolic volume. And three factors regulate stroke volume. That is the preload, the contractility of the left ventricle, and the afterload. Now I'm going to take these variables one after the other. Preload can be defined as the degree of stretch of the cardiac myocytes prior to contraction. Now, as during relaxation, the ventricles begin to fill with blood. And as they are filling with blood, it causes a stretch of the myocardium. And like I said, the preload is the degree to which the myocytes or the myocardium stretches. So sometimes this preload is thought of as the amount of blood in the heart at the end of diastole. So technically, they are not the same, but sometimes we use preload and end diastolic volume interchangeably. And this is because you most times cannot measure the preload clinically. Now, this preload follows the Frank Stelling's law, which states that the strength of cardiac contraction is dependent on the initial fiber length. In other words, the more the myocardium stretches, the more it's going to contract in systole to push out blood. So if you have more blood in the left ventricle at the end of systole, at the end of diastole, the myocardium is going to stretch more to contract during systole to push out, whatever was in the ventricle at the end of diastole. So you have a higher stroke volume. And as you can see in this ventricular function curve here, on this axis here, you have the end diastolic volume, while here you have the stroke volume. As the end diastolic volume increases, you can see that the stroke volume also increases. However, this is not true for a heart that has failed, because at this point, the myocytes have become overstretched, and the number of overlapping cross bridges are reduced, thereby reducing the contractility. So even if you increase the end diastolic volume, that is not going to increase the stroke volume. So what are the factors that affect preload or the end diastolic volume? We have the venous return and we have filling time. Now, this venous return can be affected by 4 factors. One is the blood volume. If there's an increase in blood volume, it means that we are going to have an increase in the venous return, and subsequently an increase in the stroke volume, and then an increase in cardiac outputs. Now, we also have what is known as the skeletal muscle pump. As muscles contract, particularly the muscles of the lower extremities contract, they compress on the lower extremity veins, thereby pushing up blood back into the heart. So the skeletal muscle pump also, increases venous return, and that also increases stroke volume, and by that also causes an increase in the cardiac output. Same thing with the respiratory pump. Now, the respiratory pump is basically when the diaphragm contracts, which, as we know, is an active process. And when the diaphragm contracts, it causes a negative intrathoracic pressure while causing a positive intra-abdominal pressure. Now, the positive intra-abdominal pressure compresses on the abdominal vessels, that's the IVC in this case, pushing up blood into the thorax and into the heart. Now, the negative intrathoracic pressure causes like a sucking-like kind of effect that draws blood from the IVC and even the SVC into the right ventricle. So that increases, these two mechanisms will increase the blood flow or the venous return back into the heart. And this increases stroke volume and as well the cardiac output. Now, the venomotor tone also plays a role in venous return. The more the veins contract, the more the squeeze to push out blood into the right ventricle, into the right atrium, and then thereby increasing the venous return and stroke volume and cardiac output as well. Then filling time also has a role to play in preload. The shorter the filling time, the more there's room for the cardiac chambers to fill, and in this case, the ventricle to fill. And the more the ventricles fill, the more the myocardium stretches. If you remember the Frank Stelling's law, the more it contracts to push out blood. So this, has a role to play, or this rather increases the stroke volume, and also the cardiac outputs. Now, the next factor that affects the stroke volume is the contractility. Contractility simply describes the force of myocyte contraction, and this is referred to as ionotropy. It represents the intrinsic ability of cardiac muscles to generate a force, and this is independent of any load. As the force of contraction increases, the heart is able to push more blood out of the heart and thus increases stroke volume. There are some factors that affect contractility. Importantly, the sympathetic nervous system via catecholamines, which bind on the beta-1 adrenergic receptors. Basically, what this does is that it increases intracellular calcium concentration that leads to an increase in the cross-bridging of the filaments, leading to increased contraction. Like I said, increase in contraction is going to lead to an increase in stroke volume because the force that's generated will push out more of the end diastolic volume. Then the thyroid hormones too increase the contractility of the heart, as well as some drugs like digoxin, dopamine, and dobutamine. Now, the final determinant of stroke volume is known as afterload, and it represents all the factors that contribute to total tension during isotonic contraction. Afterload can be related to the amount of systemic resistance that the ventricles must overcome to eject blood into the vasculature. Now, in simple terms, afterload is basically the resistance that the heart has to overcome in order to push blood into the systemic circulation. And this afterload is proportional to the mean systolic blood pressure, in that is closely related to the aortic pressure. Now, this afterload on individual muscle fibers is often expressed as the ventricular wall stress. And afterload basically follows the Laplace law, in that it is directly related to intraventricular pressure and size, and is inversely related to the wall thickness. So what this means is that when there's an increase in the wall thickness, it causes a decrease in the afterload. This is because the sharing of the wall tension amongst the cells of the myocardium. And then for the intraventricular pressure, as there's an increase in EDV, there's an increase in the ventricular radius, and therefore an increase. Sorry, let me just go over this again. Sorry. I said that the afterload actually follows the law of Laplace. That's Laplace's law. And this states that afterload is directly related to the intraventricular pressure and size, and inversely related to the wall thickness. So if there's an increase in the intraventricular pressure and size, there's going to be an increase in the wall tension. And we said that you can actually relate wall tension to the afterload. So an increase in the EDV will increase the ventricular radius, and then this leads to an increase in the afterload. Now, same thing with the myocardial wall thickness. There's an inverse relationship here. As the wall thickness increases, there's a decrease rather in the afterload. Now, afterload can be affected by these two factors here. If there's an increase in vascular resistance, and if there's valvular damage, for example, if there's aortic stenosis, for example, that is going to increase the resistance which the heart has to overcome to push out blood out of the ventricle. So I think that is all I have for now. At this point, entertain comments, questions, or any contributions.
Thank you for the presentation, Shifima. This time I want us to give our comments and contributions or questions for the presenter.
Thank you for the presentation. Please, can we see the question again? Dr. Shuka.
I'm trying to open
The question says, discuss the determinants of cardiac performance. So in summary, basically, like I said earlier on, well, from what my research, when you talk of cardiac performance, they are basically discussing cardiac output. Cardiac output is basically, the stroke volume times heart rate. So you are discussing those factors that affect the stroke volume and then factors that affect heart rates. So for stroke volume, it's afterload, the contractility of the heart, and then preload. So you discuss the factors that will affect these three variables. Afterload, contractility, and preload. While for heart rate, you also discuss the factors that affect heart rate. That's a summary of the. Sorry, my network went off. So I don't know if you heard the last thing I said. I said that basically what you're discussing when we are talking of cardiac performance, we're referring to the cardiac output basically. And then we're discussing the variables that make up cardiac output, which is stroke volume and heart rates. Then stroke volume also is made up of three variables. That is the preload, the contractility of the left ventricle, and the afterload. So you discuss the factors that will affect these three variables, at the same time also discuss factors that affect the heart rate. That's a summary of the discussion.
Thank you.
Hello. Hello. Yeah, well done, Chivima.
Alpha, Dr. J, are you true? Sorry.
Yes, I'm true. My network is actually very.
Sorry, my
I don't know if I'm the one who is not audible or if it's Dr. Godia.
Okay, at some point, Sha, your network was a little bit itchy, but I'm so sorry I left at some point. My itchy. I'm the chief resident, so my HOD called me for 1 or 2 stuff. So I didn't get the other part, but I think others got it. But at some point, the network was not too clear. I don't know if we can take contributions. I think Prof is on the call and others. And then Okogun is available to take his part too. I couldn't get through to Awuna. So good morning, good afternoon. Sorry, good evening, Prof.
Chief Reg.
Thank you, sir.
Yes. God bless you, sir. No, it has been a very exciting lecture given by our chief. So I just believe that when a question is going to be set on this, it will be more in form of a pathophysiology. See, the stations have headlines. So there will be like 18 stations. So each of those stations have headline for its questions. So the headline will be the topic. So now, being putting in perspective the topic presented, it's important to know that this kind of topic can come under pathophysiology. So they can just ask you about the mechanism of cardiac, something about the mechanism of cardiac function, okay, which will come, or talking about cardiac hemodynamics. So where you will need to talk about the preload, afterload, and things like that. So it would be good if Dr. Yima can help us summarize in 10 minutes the mechanism of cardiac function using the topic he has presented. It is wide what you've presented, but it would be good if you can summarize it in 10 minutes, as in putting in perspective the question comes out in the station. Thank you.
It's just one
Chief
minute.
Yima.
Let me step out. My network here is very bad. Let me just step out. Just a minute, please. Okay. So like cardiac output basically is the amount of blood that is pumped out by the heart in the minute, and it's made up of, or is derived from, an individual stroke volume and the heart rate. And alterations in these variables can also alter the cardiac output either positively or negatively. Now, the first variable here is the stroke volume, which is the amount of blood that's pumped out by the ventricle per beat, and this is usually in mils per beat. And this stroke volume, in turn, is affected also by 3 variables, which is the preload, the afterload, and the contractility of the heart. Now, the preload basically clinically can be related to as
Dr. AG. Dr. AG.
Yes.
Dr. AG.
Yes, I
So
can.
sorry. Maybe it's my network, but I didn't get the first part. It seems to be network.
No, it's actually my network. You know, I told you I traveled this week, and then where I am right now, the network.
Yes. Okay, all right. Sorry. Just go ahead. I thought it was.
Okay. So I was talking about the preload. So the preload in clinical terms can be referred to as the end diastolic volume, though technically they are not the same. Preload is basically the degree of stretch of the cardiac myocytes, but this is dependent on the amount of blood that's in the ventricle at the end of diastole. So even though they are not the same, clinically we can actually relate them to be kind of similar. So the more the left ventricle fills with blood, the more the cardiac myocytes are going to stretch in order to push out blood. Now, this becomes important when an individual requires more cardiac output to meet the needs of the metabolizing tissues. For example, in somebody who's exercising, there has to be an increase in preload in order to increase the cardiac output. And this can be done either by increasing the venous return or by increasing the filling time. Filling time simply means the time required for the ventricles to fill up with blood. So the longer the filling time, the more the ventricle has more time to fill with blood, thereby increasing the end diastolic volume and the preload in turn, and also the cardiac outputs. The other factor that affects the stroke volume is the contractility of the heart, which is the force of myocyte contraction, and is also known as anotropy. Now, when the heart muscle contracts strongly, it's able to push out more blood, thereby increasing the stroke volume and also the individual's cardiac output. And there are several factors that can actually increase the contractility of the heart. Importantly, the sympathetic nervous system, the thyroid hormones, and certain drugs like digoxin, dopamine, and dobutamine. And this increase in contractility has been utilized a lot in patients who have heart failure. For example, digoxin is a drug that we know has a positive inotropic effect that increases the intracellular contraction of calcium, thereby increasing the force of contraction of the myocardium and leading to an increase in the stroke volume and cardiac outputs. The other determinant of stroke volume is the afterload, which is, the resistance that the heart has to overcome in order to push out blood. So if there's an increase in resistance, it means that the heart will be unable to push out more blood, thereby reducing the cardiac output. And if the resistance is reduced, the opposite is going to happen. So in cases of aortic stenosis, for example, there's an increase in resistance to blood flow from the heart, thereby increasing the afterload. And this is going to negatively affect the stroke volume and also the cardiac output. Now, the other factor that affects the cardiac performance, that's cardiac output, is also the heart rate. The faster the heart beats, the more the cardiac output, and the slower it beats, the lower the cardiac output. There are several factors that can affect the heart rates, and importantly is the sympathetic nervous system via the autonomic nervous system via the sympathetic and parasympathetic nervous system. The sympathetic nervous system via catecholamines will cause an increase in heart rates, thereby increasing the cardiac output, while the parasympathetic nervous system will cause a decline in the heart rates, thereby reducing the cardiac outputs. And then we also have other conditions or factors that might also affect the heart rate, including thyroid hormones, the temperature, some electrolyte abnormalities, hypoxia, and even physiological conditions like the age of the patient and even the sex of the individual.
2 minutes more.
Okay, I'll finish, sir.
So did you say anything about afterload?
Yes, sir.
Okay, thank you. All right. Thank you. Just know that everything has to be timed in 10 minutes.
Okay, sir.
Okay. Thank you.
Thank you so much, Prof, for that, for bringing the summary. That's actually helped me to understand what we are saying. And then if there's any other contribution before Dr. Kogun or Dr. Koswa presents.
We wanted to contribute, but Prof have already contributed, so our own, not the time again.
No.
Dr. Kogun or Akoswa. Dr. Akoswa, you can go ahead. I can't find Dr. Okay, Kogun is there. Kogun, please, if you are around, just you can start here. Okogun. Okay, so I think she is not close by. Akoswa, you can go ahead.
Departmentally based today with his book. So I think you are Dr. Kuso.
Okay. Dr. Akoswa, please, can you go ahead?
I'll share my screen.
All right, perfect.
Sorry. Good evening, please. Discussing the West Africa College April. Sorry, this is supposed to be 2022. Question 3B. It says heart failure that has become refractory. So this that I used, I found. Please, I hope you can hear me.
Yes, you can hear you. You can hear you.
Please. So some of the challenges that are associated with managing advanced heart failure that has become refractory, I got 10 points. The first is that there's a persistent need for inotropes in such patients. So you have to give the patient inotropes or like maybe beta agonists like the vitamin or dopamine to keep up their circulation, because these patients often come in shock with low BP. And then the fourth problem is in facilities or areas, in environments where they can afford the use of ICD, the patients would require one with heart failure that has become refractory. And this, the challenge here is cost. It's very exorbitant and even not available, even in advanced countries, not available to everybody, financial availability and all that. So, and then there's also the problem of the discomfort of receiving frequent shocks when an ICD is implanted. And we know that from the guidelines, ideally every heart failure with an EF persistently less than 35%, after 3 months of maximal doses of guideline-directed therapy, the patient should get an ICD implanted to prevent all this lethal arrhythmias that can lead to sudden cardiac death. But usually in our environments, it doesn't even come into the picture because of the challenge of the lack of availability. And then also we have the problem of frequent hospitalizations. So we know that anytime there's hospitalization, there's the issue of time, the drain of the finances of the family, and then also the patient is exposed to nosocomial infections with each hospital admission. There's also the risk of getting a DVT, bed sores, and so many problems, because the patients with a refractory heart failure would be coming on admission very frequently. Akin to this is the problem of edema. They get very bad refractory edema. Patients cannot walk well because their legs become heavy. They develop stasis dermatitis from this chronic edema. They may also have venous ulcers. And then the patient may also have electrolyte imbalance from the high doses of diuretics. Most of these patients in our environment, after being on high doses of loop diuretics, sometimes we may add something like metolazone. And we know recently from the recent guidelines, they are often here very sequence and the rest, but the patients are prone to electrolyte imbalance. And then, like I've said already, there's persistent hypotension, and then there could be cerebral and other vital organ hypoperfusion. And then patients have you cannot into treatment. Sometimes you want to titrate up maybe your ANIS, but the patient's BP is persistently very low, so you cannot give your maximum guideline directed therapy. And then another thing also is that frequent acute decompensations are very deleterious to the patient, because each time a patient in heart failure rates for mortal challenges, that with the heart failure that has become refractory, you are going to get frequent decompensation, and then the frequent decompensations too will lead to an overall worsening of prognosis, because each time they decompensate, they never get back to the same level. They come closer and closer towards increasing mortality. And then lastly, systemic challenges in an environment like ours. So there's shortage of ICU, HDU space. Even in hospitals that you have ICU, HDU available, they are often overwhelmed. There are few facilities there. So you have so many patients scrambling for very little ICU, HDU space, and even some because of the higher cost of running those places, patients cannot afford, so you cannot get them the needed care in this ICU or HDU space. Also, we don't have access to CRT or ICD or pacemakers here. So like I've said already, patients with heart failure, EF less than 35, persistently less than 35 for more than 3 months, patients should ideally have ICDs, but usually in our environment, we don't have access to these devices. We don't have also CRT therapy available. We don't have left ventricular assist devices. We don't have access to advanced cardiac advanced heart failure support like left ventricular assist devices. We don't have access to cardiac transplantation for those who have defied all guideline mediated therapy, and then so this becomes a challenge. So we also don't have access to things like electrophysiology. Maybe if a patient has a recent onset of atrial fibrillation on top of a chronic heart failure who needs to be ablated immediately, we don't have access to all those things. So overall, managing patients with refractory heart failure becomes challenging in our environments. Other environments, we have special problems with systemic challenges, with financial issues, and lack of this advanced heart failure therapy. So it becomes difficult to give the optimum or the best. I'll pause here for any additions.
Thank you so much, Dr. Akuswa, for that very sharp presentation. The floor is open for any contribution or question. Mr. President, sir, over to you, sir. Or Tunji, anybody, please go ahead.
Oh, thank you, sir. I just want to call attention to the definition of this advanced heart failure itself. I noted that you still reference CRT, ICD. But in refractory heart failure, in its definition, these are individuals that still have some persistent symptoms, despite maybe optimization of medical, even devices like CRT, like ICD, and also even some have had some surgical treatment that still have the symptoms. So I was thinking maybe from that level, we start talking about no availability of left ventricular assist device, cardiac transplantation.
Yes, I
So I was
think
thinking
all of
that's
that
where
will
we
fit
should.
into the last point. Okay. Oh, I
Yes, I
think
get you.
if I get you right, what you mean is that this is after all the guideline maximum doses of guideline directed therapy has been used. So we should rather speak from the non-availability of
yes, maybe never
devices and all that.
How easy to get. But as far as this advanced heart failure that has become refractory is concerned, I felt that the issue of CRT, ICD, and all those things, probably the patient is still symptomatic, despite having all these CRT. And of course, there are other challenges about maybe if the like all these CRT, ICD, interrogating it, if they actually working, if the patient meet the criteria. So I feel the discussion have emphasized more on left ventricular assist, no availability of left ventricular assist device, and also how easy it is to assess cardiac transplantation.
So in essence, you are saying that this question is indirectly asking about challenges of heart transplant in our environment, right?
No, not necessarily. All the other points that she mentioned, I think are part of it. It does that last statement that no availability of CRT, no availability of. I think that when it comes to this particular refractory heart failure, it's assumed that those ones are accessible or they have even been used, and the patient, for those that qualify for them or those that met criteria for them, and the patient is still symptomatic, then it becomes a refractory. So at that point, you now start talking about left ventricular assist device, cardiac transplantation, and now it's also now this left ventricular assist device, either a destination therapy or breathe therapy or whichever it is. So I think that's the point I want to make. But of course, all the other points, fantastic. Thank you.
Thank you very much. Well noted, sir.
So thank you so much, Tunji, for the contribution. Mr. President, what Babalawa, anybody please?
I'll be like a DSS on the background, is it?
Yes, you are now LUPO.
Loopy. So I'm sure these are challenges of managing these cases in Nigeria, because in other clients, some of these things are available, like you have just noted. Perhaps the most challenging in developed country has to do with heart transplant. Even that can also add you to the list, and if you meet the requirement. Also call for the fact that I think a lot of things in Nigeria, in our country, we really need to change a lot of things, because if some of the things we are going through now as a country invest too much in some of these areas of health and make a lot of money available for insurance, some of this will be sorted out. I can tell you that Prof in last week, doing a lot of ICDs, a lot of pacemakers, even at cheaper cost to patients because of donors are ready to release a lot of money. So true, these are challenges, but some of these challenges are much more in the developing countries and less in the developing countries. So that's just my own little thought. Yeah, thank you.
Thank you so much. So, Prof, if there's no any other, I don't know if I may be correct. I would have answered this question in addition to what she has done by giving a brief definition of the various spectrum of heart failure down to this advanced heart failure. And then probably I would have actually touched beyond patient management to the economic side, insurance, and co. So I don't know if I would be correct if I had gone that way. Okay, Prof, I don't know if you can give us your thoughts and guide.
Yeah, thank you. So thank you, Dr. Oswa, for this presentation. And thanks for the highlights. Okay, so it's important to also state there that when you are discussing, I wish to actually see the question very well. Maybe if you can go to the question. Said, as a consultant, can you discuss advanced heart failure that has become refractory? Okay, so see, they are asking, I think this question is more to be answered based on your local practice. Okay, and as you have answered it, is the best way you should do it. Okay, because if they ask you now, like Dr. Tunji saying that you expect that refractory failure should be patient that had all the devices before they become refractory, then the question they will now ask you is that, please, how many patients with advanced heart failure in your center has had all the devices? You get me, Dr. Tunji? They put that question to you, that what the percentage of patients that have advanced failure have gotten devices? Because they're asking you as a consultant cardiologist practicing in your center now, what are the challenges of managing advanced heart failure that has become refractory? Okay, so if you are telling us that in your center, all the patients with advanced heart failure have gotten either ICD, CRTDs, and all that, are you beating your chest to tell us that? You get what I mean? That means you will not be having more challenge to talk about. It should be like Dr. Kweki over there, just talking about heart transplant. But if you are still practicing in this environment, I think the way Dr. Koso has approached it is the best. I'm telling you, or Dr. Kopi, everybody with advanced heart failure center have gotten devices.
Some of them don't even have the
medical therapy, but as field therapy. So, therefore, what are the challenges of now advancing their therapy? So the devices come in, the assist devices, as you said, also comes in, the transplant issue also comes in. So the way she has gone about it is fantastic. Okay. So, but the part that I think she has not really discussed is what are the management plan for these patients? Because I think the question is like 2 in 1. That's why I said we should go back to the question. The challenges, and so it's not just talking about the challenges, also the solutions to it. Because they're asking you as a consultant cardiologist, discuss challenges of managing. Okay, so yeah, the challenge. Okay, because you've listed for us the challenges. Then the next thing is to now list for us the options, management options for them. Okay. You know why I say you should list management option? Because I'm sure the only two you have in mind is talk about left ventricular assist device and heart transplant. Abi?
Yes.
Akuswa.
Yes, I think yes. So I mean, in an environment that is available, so you need a left ventricular assist device as either a destination therapy or as a bridge to transplant, and then what you just said means that we have to find a way around some of these things too, but a lot of it are systemic challenges. So I think for the lack of access to the left ventricular assist device, lack of access to transplants, for the 10 points, I could have elaborated further to say that, to talk about even the challenges that patients who, a little about transplants, and even the challenges that patients who go through transplants are likely to face. I think that if I understand clearly what you're saying, sir, you are meaning that some of the problems that I've listed to, I should try and talk about some solutions. What's the solution to it? The ultimate solution would be transplant, but transplant itself is not without its challenges. Even in an environment that has access to transplants, you have the issues of immunosuppression, rejection, and infection, and all those complications also to worry about. So I think that I agree with you, or the question can go in so many ways. So yeah, I've noted all the corrections. And then maybe in our environment, we're talking about a lot of the systemic challenges. Dr. Kweki mentioned about insurance and then availability of some of these devices and access to the insurance and all that. So it's I'm just looking at listening to all of you on how maybe we can agree on a way of how it should should go, because it looks like there are a lot of ways that you can look at this kind of question. Thank you very much.
Thank you so much, Safo Akuswa and Bob, for the very scintillating presentation. So, Prof, I don't know if she should do it in 10 minutes or she should just update this.
Yeah, you get what I mean?
Yes, yes, sir.
So we need you to know other advanced therapies and transplant. That's what we're saying.
Okay.
You get?
Yes, please.
Yeah, so that's why you have to read management of refractory heart failure. You get? So you know why I'm saying this? Because you only sit down and just roam around challenges around your environment, why patients cannot get advanced medical therapy, advanced therapy for heart failure. Okay? But the question we're asking is that now, what are these other advanced therapies that you want them to get? That's why I said the questions is 2 in 1. It's not just to rule out problems. You should profile solutions. What are the other advanced therapy? Is it only LVAD and heart transplant? So you can see the catch where the examiner can hold marks from, from the candidate. So we need you to talk about that. Chief Okopi, I don't know if I'm clear enough.
Yeah, yes, sir, you are very clear, sir. And I think we have even discussed this advanced therapy.
Okay, Dr. Akosua, over to you. 10 minutes. 10 minutes. Discuss this question.
Okay. So so I should take it in the direction of the advanced therapies for managing heart failure. So okay, so let me see.
Just assume that you are before the examiner, Professor Okialam and Professor Karaye and Professor Umbakwe, 3 of them.
But she will do our own in Ghana now.
No, they came to Nigeria the last time. Is it not?
So the presence of those guys you mentioned, oh, it's not easy.
Okay, so
Those 3 guys you mentioned, sir.
So what I would say is that, okay, so for managing heart failure, so I'm managing this patient comes, patients probably has heart failure with reduced ejection fraction, EF less than 40. So you start with your initial guideline directed medical therapy, your ACE inhibitor, ARBs or ANIs. You've done your maximal doses of beta blockers. You've done your mineralocorticoid antagonist, and then you've done your SGLT2 inhibitor. And all these are at maximum doses. Patient still has EF less than a patient is edematous, patient is breathless, patient has maybe class 3 or class 4 symptoms still. Maybe one of the things that you should think about is after 3 months, if this patient's EF is still less than 35 on this maximal doses of guideline directed therapy, maybe you should think probably of inserting an ICD for the patient, so you can put in an ICD. And then an important thing to think about is trying to get to the underlying cause of the heart failure. Because, for instance, if this heart failure is from valvular heart disease, or it's associated with severe or persistent or what should I say, persistent or long-standing persistent or permanent atrial fibrillation, or there's bradycardia and other arrhythmias or dysarrhythmias associated with this heart failure, obviously it's not going to get better. So one of the things that one has to think of is managing any underlying issues. So if it means, or if the patient has ischemic heart disease, if the patient has ischemic heart disease, maybe you might think of doing an angio and seeing if the patient, if treatments with angioplasty would help improve the patient's state a bit. For instance, if a patient, the underlying cause of the heart failure is coronary artery disease, maybe if you do your angioplasty, it would help a bit. And then you also, for valvular heart disease, I mean severe valvular heart disease, patients heart failure is resulting from valvular heart disease. You might do all your maximal medical therapy, but not, the patient will still be refractory. So you have to discuss with a heart team and evaluate the patient. If this patient qualifies for a valve replacement or repair, would help to improve the symptoms. So if the patient has a prolapse or any other valvular disease, you use the correct surgical repair method to assist the patient. If the patient is on admission and the patient is in ICU and the BPs are progressively low, getting lower in spite of all that you've done, you can still, as you arrange arranged and organized for transplant, some of the things you can do, you can admit the patient at an ICU. There's several mechanisms for helping them, like an intra-aortic balloon pump. There's also the impeller device, the tandem heart device, and then you have your left ventricular assist device, which can either be used as a destination therapy or a bridge to transplant. As for the transplant, it's your last option when all these things have failed. Then maybe you want to refer the patient to a transplant specialized center so that they would assist, they will assess the patients for possible heart transplant. So this is what I thought that.
Well, Dr. Akoso. Nice one. So I was trying to interrupt you at a time that you made a very important point. And that is very important point. I hope I'm audible, sir.
Yes, please go.
Yeah, so you made a very important point that just fetched you 5/10, the mark, identifying underlying etiology. Chikweki.
I'm here.
Yes, I remember this was our question.
Yeah, I remember this question.
One thought station.
That about was the one that station.
In that station, and when move stop, finish. Person now asked, please, did you even know the etiology of the artery? We have moved all this stuff. So what I'm just trying to say is that she made a comment, a very fantastic comment, finding the etiology of the artery and treating in the line of the etiology is already 5 marks. Okay? So that's why we're trying to emphasize. All of us were just saying we'll do transplant, we'll do whatever. They were just looking at us. And the lady just stopped me as they wanted to ring the bell and said, come, doctor, please, do you even know the etiology of this artery? If you don't know the etiology, you get what I mean? The patient will still be in refractory heart failure. So I appreciated the fact that she mentioned that fact, that finding the etiology or finding solution to the etiology. Because I'll give you an example. Let's say a patient has cardiac amyloid and has heart failure. Abi, you want to do transplant, Abi? Dr. Koswa.
Yes, please.
Right? You know that the same amyloid can occur in the grafted heart.
Yes, please.
I hope you know.
Yes, please.
Yeah, because if the person has the abnormal protein still produced either from the bone marrow or from the liver, it can still deposit in the new heart. So it's not like transplant is the ultimate solution. You get what I mean? Recurrence of amyloid can happen in a transplanted heart. So we're just trying to say that finding the etiology, we're just trying to draw the attention to finding the etiology and providing solution to the etiology should not be undergraded. So I'm sure people on this platform, maybe when they get to the station, they'll feel that refractory heart failure means that I provided solution to the etiology. That's not the definition of refractory heart failure. Refractory heart failure simply means that this patient has been on optimal medical therapy. He has heart failure of usual fashion, has been on optimal medical therapy, but still in NYHA 3 and 4 with a reduced AF. But the question is, the definition has not talked about identifying the etiology and providing solution to the etiology. That's what we're trying to emphasize. So we need to find that etiology and provide. You have to say it in the exam. Don't assume that the examiner thinks you sorted that. Okay? So please, there are also other modalities. As you mentioned, you talked about other modalities for management, which you talked about IBP, you talked about LVAD. There are other types too. There are steps where you can do even ultrafiltration. I don't know quickly if they do some over there. Because there's a place for ultrafiltration. There's a place for implanting devices in the pulmonary artery so as to monitor the pulmonary wedge, so as to know when to diurese this patient and things like that. There are devices for that monitors, and they found out that patients that have those implants into their pulmonary vasculature do better when they are with titration of their medical therapy. Okay, so I've just forgotten the name. I don't know if you remember the name of those. Someone can remember on the group that they implant into their pulmonary vasculature. It's just to monitor their preload, their feeding state, and it can also help to monitor. After monitoring that, they can use it to titrate their medical therapy, and it has shown that it has improved their long-term survival. So not everything is transplant, not everything is LVAD. You get me, ma?
Yes.
There are still other therapy that can be given. Okay, I wish you the very best.
Thank you very much.
Thank you so much, Prof. Thank you so much, Kweki. Thank you so much, Boris Safo. Interesting presentation. We can have the next person, please, if there are no contributions from any other person. We have Dr. Okogu. Okay, sorry, Dr. Okogu, for the presentation.
Sorry, good evening.
Yeah.
Hello?
Yeah, we are here. I can hear you.
Hello?
Can hear you, Dr. Okogu.
Is it me you've been calling since?
Yes.
Yeah, is it my name you've been calling? I presented.
Yes.
Is it not the resistant hypertension and the other? Or is it? That's like last week or 2 weeks ago.
Oh, okay. Sorry, Dr. Chuka. Who else? I called Okogu instead. I didn't know. Dr. Chuka.
I'm trying to check the names now.
All right. Okay. Let's just wait. But if you are around and you have. I'm just seeing one very interesting name, Dr. Yekachi Aguta. It's like the first time I'm seeing the name. Dr. Aguta, well done. How are you, sir?
One Dr. Chika has not presented.
Yes. We have one Aguta on the call today. Aguta, how are you, sir? Interesting. He just connected. And then Techno Canon 15. All right. Is there anybody on the call that has
and Dr. Awuna, that's something Dr. Awuna has presented too.
Okay, she's unavailable.
Dr. Chuka, if anybody is not around, I think we should just answer the question. The next 2 weeks, you're going to be in the hall anyway to answer the whether you like it or not.
Yes, let's just answer it, then we'll move on.
Just discuss it. Just discuss it, and then we'll move ahead. Because this is barely 2 weeks still about to the exam.
Yeah, this is not December 15th.
So I think we should just watch the question left. Let's discuss them and then move on. Sometimes you don't need all the stuff to pass the exam. Just hit the nail on the point, and then you are good to go. If they are marking all your little errors, in the exam, I don't think anybody will pass. So it's not a perfect exam. They are looking for 50%. Not perfect exam. So let's just discuss.
Let me take off it. Looking at for the pre-op management of the patient that is meant to go for cardiac surgery, diagnosis. The cardiologist is the one that first makes the diagnosis and then decides that this patient requires cardiac surgery and makes refer to the cardiothoracic surgeon. He is the one that will first see the patient, get the history, and then investigates, including the imaging investigations like echocardiography and other investigations to confirm the diagnosis and what problem patient has, as well as to stabilize if patient is unstable, as most patients that require cardiac surgery may be unstable at time of presentation and will not be taken into the theater if they are still unstable. So first of all, the cardiologist will have to be there to stabilize the patient as well as reduce the be the first to stabilize the patient as well as give make the referral to the cardiothoracic surgeon. Then leaving the cardiologist and the other teams that they come in depends on now whether it has other comorbidities or not. First, you also have the nursing team, preferably cardiac nurses, who are meant to help in the care of this patient, the pre-op care of this patient, in preparing this patient for the surgery, and then making sure the patient gets the appropriate care. Requires some special needs. For instance, some of them like if it's for kids like cabbage, some of them may be unstable and require close monitoring in the ICU. So they require ICU nursing care. So that's the next thing. Then the other thing includes if the patient has some other medical comorbidities like diabetes, may require the endocrinologist to come in to look into the patient to help ensure she has proper glycemic control. Or also if patient has a concurrent respiratory problem, require the physician to come in. However, if these comorbidities are not there, the cardiologist is the major person that comes, and then you have the cardiothoracic surgeon who does the surgery. Then the anesthetics has to come in as well, because there we have to review this patient prior to surgery to establish that the patient is okay and be able to take the surgery as well as prepare for the surgery. Okay, these are the major things. Then you still have other non-clinical staff that patient may need, including the laboratory components. We have actually require some laboratory investigations, where both chemistry and hematological as well. We have this for some hematological investigations, some laboratory investigations. We have need of the blood bank, because most times in the theater they need to have at least 4 units of blood most times here, in case patient needs transfusions. And we have to look to have that um, um, the hematologist to prepare that. Then also we mainly the radiographers to radiologists to condition the requirement of X-ray and X-ray, which is meant to help to delineate and evaluate this patient properly before the surgery. So we need the radiologist and radiographer to get the X-ray images for the patients. And then you see how we become to counsel these patients on the possible social aspects of the surgery and the possible social needs patient may have in the post-op period. Though sometimes this is now done by the cardiologist and the cardiovascular surgeons, but there should be the social worker should be there to help especially with the needs of patient. Some of them may also have financial needs as well. Not concerned that this may come under the social work help workers help us with. They have to have the pharmacist too, who has to make sure the drugs are all available, both the drugs needs to take to stabilize, down to the drugs that we really needed intra often by the anesthetics and the surgeon surgery, as well as the post-op period too. So the anesthetic has to come into play in the whole picture to help in this the service of the program. Then she also have to talk about the biomedical technicians too, who are there to ensure that all the equipments that are needed are working well. Your cardiac monitors, your machine, the heart lung machine, and all the technical machines, that even your ventilators and everything is working properly. Like before the thing is good about the fast them to come out of it and so that your heart lung machine is not your the ventilator is not working or instead of discover the hand machine is not working after you're going to constantly bypass. So you will need that. Then sometimes we need the interventional cardiology profession that may have some pressure issues that once we measure the pressures and then we find the right categorization, the pressure measurements and so we need the interventional cardiologist at that point in time. Um, then you see I think these are the major things that are involved in the pre-op creation of the section that's trying to go from cardiac surgery. I think I'll pause and take comments and questions at this point. Hello? Hello?
I think we're hearing you. Copy, are you still there?
Okay.
Yes, I'm here. I'm hearing him. There's this itch in his network, but I'm hearing him. Shuka, please, we are hearing.
He's done. He's done.
Hearing you, please. You can go ahead.
He's done.
Oh, he's done.
Yeah.
Somebody was calling me, distracting my network. All right. Contribution, please. Contribution. Mr. President, Dr. Ishaya, Godia Dare. Dr. Ishaya, Godia, we're waiting for you, sir, for your contribution. You know, the person that was supposed to answer the question is not on ground, so we want to do mind rubbing. So, Dr. Ishaya, what would be your side? And then there's Dr. Fatima. Dr. Fatima.
Yes.
Please, what's your contribution to this question?
Hello.
Yeah, we can hear you, Dr. Fatima. Okay, maybe our network is poor. Let's have Dr. Jacqueline Ejetu.
Yeah, I heard
Jacqueline,
you calling my
please,
name.
what's your contribution?
Yeah,
Unfortunately, Dr. Fatima's network is poor. It seems the network this evening is poor, almost all around. Yes, on the question Dr. Chuka just answered.
I don't have contribution. He did it well.
Okay, thank you so much. All right. So I don't know if there's any other person, Dr. Jacqueline. Dr. Jacqueline, she's not there. All right. So, Prof, sir, if you can help us out. Oh, okay, good. Is there the question he just answered? If you have any contribution or clarification?
No contribution.
Okay, so Prof, sir, if you can help us out, Dr. Tony, floor is open to you guys.
I think he did a great job, but just to add to it, things like that, always follow this pattern: introduction, the body and conclusion. Introduction, the body and conclusion. So introduction like teamwork in cardio practice or in the cath lab or in the cardiovascular center is very important and essential to reduce morbidity and mortality of patients. Give an introduction like that. Then you talk about the body, all these measurements, then in conclusion. So all this kind of statement, follow that pattern, you will always not go wrong.
Thank you, sir.
Thank you, Dr. Kweki Tony. Prof, sir. Up to you, sir.
Can you help with the question? Can you post the question? Is it possible?
Let me try. Let me put the question, sir. That's the deep question, sir.
Okay. So what are the teams involved, right? This is question 6B, right?
Yes, yes.
What are the teams involved in pre-op management of a patient with you? Yeah, so to me, because I think you spoke for like 15 minutes. I don't know because I was wondering what was the question. Because I think this question is for you to list. You spoke extensively on probably on the cardiologist, and so I was now wondering that's why I said let's post the question back. What are the teams involved in pre-op management of patients who is to undergo cardiac surgery? So what they want to hear is this, list them. I don't think there will be much mark awarded for a long talk. You know what I'm saying?
Yes. Do I attempt it again, sir?
Information, but you have to work with time and distance. You get me, sir? Because I don't think it's a hard question at all. So can you now spend 4 minutes on this question?
Yes, yes.
Yes, sir.
Let me give you a example. Okay. Teamwork is very necessary and vital for success in open heart surgery, and is required to reduce morbidity and mortality. Now, the things that are involved in the field of management of a patient planning to undergo cardiac surgery include first the cardiologist, then the cardiac surgeon who is doing the surgery, the anesthetist who is preparing the patient, the nurses, which are do the IC nurses, and then as well as the ward nurses and the cardiac nurses, then the physiotherapists who will prefer review the patient in flat for possible post-op takeover of the photography, then the laboratory scientists who will take care of the lab, then the radiographers, radiologists, the anesthetists before, then the perfectionist is the theater that will be needed. And we need other physicians to depend on if patient has comorbidities like diabetes, and maybe an endocrinologist to come in, or renal where the nephrologist may need to review. Then we need social worker to counsel patient, then the pharmacists to provide the medication the patient may need. And then the biotech, biomed technician to look at the equipment that patient will need. I think basically this.
Thank you. And thank you for remembering to mention the perfusionist. Because me and you know that cardiac surgery will not happen without the perfusionist. No.
Yes.
There's one person you have not mentioned. So, because you mentioned cardiologist, but you didn't mention interventional cardiologist.
I mentioned that the first time, and I used it this time. I was not thinking about who I was forgetting. But patient may require to go to the cath lab to measure the pressures to be sure that patient can actually even be operated. Depending on some cases, like some of the VSDs and congenital diseases, where the pressures are not right, you don't operate on the patients. The patient cardiology is very vital.
Thank you. No, okay, nice one. So you can see, you get all your mark. I mean, now you spent 3 minutes. I guess. Unlike the previous time, you spent almost 10 minutes. Because you have this is just 6B. Sometimes there can be 6C. You get what I mean? There'll be 6A, 6B, 6C, yes. You won't have time to talk a lot. All right, thank you. So Dr. Kopi, over to you, sir.
Okay, thank you so much, Prof. Thank you for that clarification. Thank you, Dr. Chuka. Thank you, Dr. Kweki.
Thank you, sir.
Is there anybody on the call that needs clarification? Okay, Dr. Jennifer Obieli. She's requesting that we kindly post our slide, Dr. Bobby Akosua and Dr. G. If we can please post our slide so that the consumption of the slide can be.
Make this into a slide and then post. Just list these things and then put in a slide and post.
Okay, sir. Hi, thank you so much. Is there any other person, please? Can we take that of Awuna, Dr. Chuka? We still have like 40 minutes. Sorry.
That's
yeah?
5-8.
Yes, we still have. $20, yeah.
That one.
Okay. Dr. Goodyear. Mr. President, sir. Hello, Mr. President.
Dr. Kopi.
Yes, sir. So sorry for calling you from the inner
Sorry,
chambers.
I'm reviewing a patient. I'm on call.
Okay. So let me call Dr. Fatima, my very good friend too. Or Dr. Babalawa
No
is
problem.
also here.
I will attempt it.
So Dr. Fatima,
No?
please. All right. Thank you so much.
Okay. The question says you are called to see a patient in the emergency room with breathlessness. How will you confirm that the patient's symptoms is due to acute pulmonary edema? They were interested in history and examination findings in this station. So the first thing is to take a detailed history of the breathlessness. I'm trying to find out the onset of the breathlessness. In the case of acute pulmonary edema, the breathlessness is usually sudden in onset, and there may be cough. Yeah, breathlessness is usually sudden in onset. There may be anxiety. There may be profuse sweating and even feeling of drowning because of the sudden onset of congestion in the chest. So about the breathlessness, you need to take a detailed history about it, whether it occurs on exertion, is it mild exertion, moderate exertion, or it occurs at rest. Associated history of orthopnea, PND, as well as cough. Yes, cough is also important. Then the cough even productive of usually a whitish frozen sputum with hemoptysis in case of severe congestion. This patient may also have a chest pain. The chest pain may be from acute myocardial ischemia or myocardial infarction, acute pulmonary edema. This patient may come with tachycardia. Yes, they are usually tachycardic on examination. Pulse rate greater than 100. Their blood pressure is usually high, usually greater than 40/90. There may be hypotension in some cases where the blood pressure may be less than 100, but mostly they come with high blood pressure. On examining the chest, they may have fine crepitations at the lung bases with rhonchi or wheezes, which may be present. But the crepitations may be had at the lung bases initially, but in severe cases, it may even be widespread crepitations. So on examining the heart, I said there is tachycardia, hypertension or hypotension. When there is, in the case of severe LV disease, heart sounds, there may be the first and second heart sound with additional abnormal heart sounds, like the S3, third heart sound, with or without the fourth heart sound, the gallop rhythm, and murmurs may even be present depending on the underlying etiology of the pulmonary edema. The extremities may be cold and clammy, especially if the patient comes in cardiogenic shock from peripheral vasoconstriction and shunting of blood from the central circulation in patients with poor LV systolic function. So other examination findings include features of heart failure like hepatomegaly, raised JBP, or even peripheral edema if there is concurrent right heart failure. Then the patient may have altered level of consciousness when in case of severe cardiogenic pulmonary edema, which may be due to hypoxia or hypercapnia. Again, in general examination, they can have come with pallor indicating peripheral vasoconstriction because of the underlying heart failure. So this is what I would say about the history and examination. However, it is important to rule out the etiology of the heart failure, of the cardiogenic pulmonary edema, etiology of the heart failure. So the patient may have underlying valvular heart disease like rheumatic mitral stenosis, as we know is an important cause. So it's important to find out the features maybe or features of infection or even patients that have or features to suggest like the these are all important etiologies that the patient that until the patient so you will also try to take history of the course of the acute exacerbation. As I said, patients with pneumonia usually present sudden onset. Then maybe even severe anemia or sepsis might have precipitated the symptoms. Sepsis given myocarditis and constantly at the beginning. So this is what I can say about the history of the
Most part of your discussion, I could barely hear you. Maybe it's my network. Um, I didn't get most part of it, but I think you mentioned the symptoms and then the signs, basically. And the next question actually pointed out an etiology, and also for you, Dr. Fatima. If it were to be a coronary syndrome, how would you manage this patient as the etiology for the acute pulmonary edema? And the examiners were interested in the thrombolytics that are present in the symptoms and how they are administered, indications, and possibly complication, I guess. So, Dr. Fatima, I don't know if you're still there with us.
Yes, I'm there. I answered this question the other time. I answered the B part. It is the A part that was not attempted. So I assuming this patient pulmonary edema is due to acute coronary syndrome. So the most important step is to help with the decongestion of the pulmonary edema. That is by prelude use of diuretics, prelude to reduce the prelude, particularly the loop diuretics. And if the patient is not responding well, you may consider giving nitroglycerin. Then afterload reduction with angiotensin converting enzyme inhibitors or the ACEIs, as well as use of vasodilators like nitroprusside to reduce the preload. Then assuming the patient came with acute, if the pulmonary edema, so now what I said is management of the pulmonary edema first. Then if the patient comes with acute coronary syndrome, giving rise to the pulmonary edema, it's important to give the patient and like particularly narcotic like intravenous morphine. Ensure the ABC of resuscitation as usual as the first step. Then try to activate the cath lab, especially if the patient presents within the golden hours before things get ready. You give the loading dose of dual antiplatelet therapy, loading dose of aspirin 300 milligrams, start loading dose of clopidogrel 200 milligrams start, then start anticoagulation. In our setting, we usually give subacute low molecular with heparin. That is the enoxaparin at the therapeutic dose of 1 milligram per kg. Then we start the patient on disease modifying agents if there are no contraindication like the beta blockers, the ACIs or the ARBs, as well as statins. So while the cath lab is being activated immediately for possible cardiac catheterization to ensure revascularization being the definitive therapy. To do either a PCI or CAVI, depending on the vessel disease, the time of presentation, depending on the number of vessels that are affected, as well as background comorbidity and availability of the expertise. So if that is possible, fine. If, however, the patient presents to a center where the PCI is not available, then we consider doing thrombolysis, that is fibrinolytic therapy. If that is available, usually in the case of STEMI, if the acute coronary syndrome is due to STEMI, you consider thrombolysis using agents like streptokinase, tenecteplase, alteplase, or tissue plasminogen activators. So the way to administer it in the case of streptokinase is usually given at a dose of 0.5 mega units in 100 mils of 5% dextrosaline given over 60 minutes. Yes, if I can remember. Streptokinase is more widely readily available especially in the developing countries. However, in developed countries, they consider the second generation agent like the tenecteplase and the alteplase. But here locally in our center, we usually give the streptokinase being the one that is more readily available. So the other agents, I think I can remember clearly the dose of the streptokinase. The alteplase and the place, I cannot remember the dose right now.
All right, thank you so much, Dr. Fatima. Any contribution from anyone? We have about 10, 15 minutes. Quick contribution before we call. Dr. Chuka, you're muted. You can speak.
So I left from the work, so I have to unmute. I have to remove the sharing. That's why I still unmuted sharing. I think I wasn't
All right.
Still was
Okay, even though your network is a little bit muffled, but I could barely hear you. I assume you're saying that you were muted because you were sharing the slides. So
Good
Dr.
answer, especially when you're not prepared. I didn't hear some part of our discussion as noted because of our network was breaking here and there. But for the part B, I know she was talking about reducing fluid overload because of the pulmonary edema and all the stuff and all that. I think the concept is just underlaid in pulmonary embolism from what I can see. And I think it's an area that all of us need to just look at for. Again, we all know that pulmonary embolism have to be stratified into low, intermediate, and high risk. I also know that CTPA is a gold standard for pulmonary embolism, and every patient should have a D-dimer. D-dimer is said to be very sensitive, may not be specific, and where you have all these things available, make life interesting. So I think she did a great job is to put all this perspective. I don't know whether she talked about CTPA. I don't know whether she talked about ventilation perfusion mismatch, where it can be used, because I didn't hear some of her talk. Issues of the management. So it's just a concept of pulmonary embolism. So it's something that we just have to just revise. That's what just my additions. You understand, Dr. Fatima?
Yes, sir. Yes, sir. Thank you, sir.
It's just something around pulmonary embolism for what I can see. Then differentials, of course, you also keep that in mind. So that is a good one. I don't have so much on really because it's something that we know. Just organize your thoughts and present it properly. Thank you.
Thank you. Thank you so much, Dr. Tony. Thank you so much. Prof, can we please have your contribution?
Okay, thank you. And thank you, Chief Kweti. Yeah, so just a quick one for her. When taking that option, question 5A, it would be good that you only mentioned, because probably the person that we called only told you is history and physical examination they're looking for. Please do not lose the portion of doing appropriate investigation. Okay, in confirming your diagnosis, you should be part of as confirming that this patient symptoms is due to acute pulmonary edema. Okay. So history, physical examination, and proper investigations. Now, there's just one thing I want to bring your attention to when you're answering option B, even though you said you've answered it before. But I noticed that your therapy was limited to when you took this person as in the acute management, when you manage this person or took to cath lab or thrombolized. Dr. Fatima, you never mentioned anything post PCI. What therapy is this person meant to continue? How long should this person be on it? We have found out that causes of recurrent, either from stent thrombosis or recurrent MI, is strongly related to post-procedure management. So the question we'll ask you is now is that, okay, after I've given thrombosis to this patient and you just discharge like that, are there other therapies this person is supposed to do? Are there other lifestyle modifications which you did not mention? Dr. Fatima,
Yes, Prof.
You didn't tell us anything about like modification in this patient and things like that. Does the patient need to continue smoking? Does the patient need to continue sedentary life? There are many things you didn't tell us. It will fetch mark for a candidate that mentioned that. Number two is that there was one interesting comment you made that still baffles me a little. When you're mentioning the types of the thrombolytics, you mentioned streptokinase, you said tenecteplase, you said alteplase, then tissue plasminogen activators, right?
Yes.
So I want to repeat what you said. You said streptokinase.
A mistake. They are tissue plasminogen activators. Yes. They are DPA.
Probably because of the network. Maybe we didn't hear you well. Because I wanted to be sure that, are you saying tissue plasminogen activator is another type? You get what I mean? Okay. No problem. I think that is already clarified. Just want to be sure. But there's one you didn't mention, Sha. You didn't mention urokinase. Okay. Thank you. So don't let me waste our time. Thank you very much.
Wow, thank you, Prof. It's not really a waste of time. You're actually giving us a lot of clarification. Thank you, sir. We are so grateful. Dr. Chuka, any more questions left for us to tackle on this oral? I think we've basically done all.
I think we've sorted out all of them.
All right, so we'll just request kindly from those that did the questions with slides to please help with the slides on the page so that we can have them handy. And then the conversion of the recordings, if Dr. AG can help us, that can be on the Telegram page too. So in the absence of any other questions, Dr. Chuka, so over to you. Take care.
Thank you, Chief. Although not yet gotten the last report for the last exam, the orals for the last exam, we are yet to get the report for the oral for the last exam. And we are still hoping if it is possible for us to get it, although after now we are yet to get the hands from it. But all the same, I want to thank you, Chifokofi, Chifeki, Prof. Nabileji for being available to direct us through the discussion. And I want to thank all of us who were able to present and keep the spirit going and keep the fire burning. Tomorrow we'll continue with the MCQ to see if we can finish with the MCQ, hopefully. Those who are owing us questions on MCQ, please be ready so that we can move fast. But if they're done for, we know what to do. But let's see if we can finish the MCQ tomorrow, but don't have time anymore. And then Friday we'll see the some presentation, and that's the last one, I think. Unless I'm wrong, or there's another one, but we have a discussion on Friday. I think that will be all for now. Chifima, I don't know if I'm missing anything.
Okay, though, nothing much. For I just want to make a comment on the issue of the recall. So I also haven't gotten the recall, but I discussed with somebody who went for the last exam, and she was able to tell me, not recall the questions, but she told me what part of cardiology questions came from, or what topics that came out. So I don't know if that will be useful, because she made mention of oxygen saturation, beta agonist, cardiac tamponade, the role of the cardiologist, I think in cardiac surgery. So I think we need to read around those topics as well.
Okay, if we can maybe start those topics and text for us on WhatsApp so that we can read around and since we don't have the report themselves. I know that we still have the report, so maybe what we have, we can take those areas that we can look at them as well. And we discuss it with our seniors too.
And then we still have the October 2021 record, which has about 16 questions. If we're going to finish that record, then it means we need to have more days for the oral record.
If you can finish the MCQ tomorrow, then we can now fill the reforms. And then do MCQs after the done the reform, the oral. But that will be up to us. If we can finish it, we can finish the MCQ tomorrow. If that can work out, that will mean for starting on time and then start without having delays.
That's fine. Then I'll share the questions hopefully by when I'm traveling back tomorrow. When I get back in the evening, I should be able to share questions.
When anybody doesn't show up, just take the question. The exam is 2 weeks from now. There are no questions in that oral, maybe the MCQ, that are not a bit friendly. The one we don't know, we will leave them. The exam is 50% pass, it's not 100%. So that we can move fast. I expect that this week, next week, we should just run through, take the salient points and move on. Because if we are going the way we are going now, waiting for people, dragging leg, we will not get to the end. We will not, to be frank.
Okay, Chief.
So let's change a pattern. That's what I'm trying to say. Yeah, I can hear you. Yeah. Hello? You're trying to say something?
No, I think somebody's mic was on.
Okay. So that's what I think. Let's find